Hello, my name is Brianna Moore, and this is my interdisciplinary collaboration and leadership reflection video. In this presentation, I will discuss a personal experience with an interdisciplinary collaboration and explore what was successful and unsuccessful in terms of achieving quality communication and how it impacted patient care and management of financial resources. Utilizing this experience, I will reflect on how the unsuccessful part of this collaboration could be improved to achieve the desired outcome and increase patient satisfaction, as well as human and financial resources for the hospital. I will also identify best practice interdisciplinary collaboration strategies using my own personal experience. Overall, I have been a nurse for 12 years. 6 of those being an LPN and the other 6 as an RN. I've worked in clinics, nursing homes, assisted living facilities, and multiple hospitals. And due to my diverse work history, I've had many examples of interdisciplinary collaborations, some successful and some not so much. Today I want to talk about the one that I experienced during my first RN job. At that time, I worked on a trauma surgery floor, also did plastics and some ENT as well. This was at a local level 1 trauma center. This, of course, was a teaching hospital, so we had residents who we would page on, they were on call at night. If we needed anything for our patients, we would just page them at night and let them know. This one particular night, I had a patient who had had a vascular surgery to his lower left leg earlier that day. He had an extensive history, which included alcohol and substance abuse. So because of this history, the doctors were a lot more conservative with his pain medication. One very important assessment that I as a nurse completed every 4 hours after this type of surgery was neurovascular assessments. Basically, we just want to make sure that there's no changes to the patient's pain level or sensation to the affected limb. Patients are at risk for developing acute compartment syndrome after surgeries like this. According to an article from the Medicine Journal, it says, to prevent serious complications induced by acute compartment syndrome, a fasciotomy should be done before irreversible tissue necrosis can occur. Thus, there's a strong clinic bias toward doing fasciotomy empirically or prophylactically in patients who are considered to be at high risk and or who have concerning clinical findings according to that journal article. My patient, we'll call him John Smith, stated during my initial assessment at 8 p.m. that his pain was at a 2. The pulse in his foot was within normal limits, and he could wiggle his toes and feel me touching them. Later on in my shift, he called out, this was around 10 p.m., complaining that his pain was now at a 7. After looking at his MAR, I went to administer his IV pain medication that was due. My neurovascular assessment at this time was normal, other than he said he felt some tingling in his foot and he couldn't feel me touching his foot as much as he could earlier. Due to this change, I went ahead and called the on-call resident, just to let them know what was going on and that there were some changes. Basically, the on-call resident told me that this patient was just drug seeking and probably wanted more pain medicines. I went ahead and I let my charge nurse know of the situation that was going on as well. And a couple of hours later, he called out stating that his pain was worse now after the medication I had given him earlier. Upon assessing my patient, it was noted that his foot felt more cool to the touch than previous, and the sensation in his foot had once again decreased. So I once again paged the on-call resident to let her know about these changes, and she stated to just go ahead and give him his by-mouth PRN medication as well. After doing this, I waited about 30 minutes and rechecked his condition. At this point, he was in severe pain. He was tachycardic and he was diaphoretic. He could no longer feel me touching his foot at all, and his foot was very cool to the touch now. At this point, I went ahead and paged the on-call resident again, and when she called me back, I attempted to tell her of the changes, and before I could even finish talking, she cut me off and began yelling at me about the patient's history of being a drug abuser and that he was once again just drug seeking. I told her that there were clear signs of acute compartment syndrome but she hung up on me before I could even finish talking. I then paged the second on-call resident to see if he could come look at my patient. He immediately came up and assessed my patient and stated that the patient needed an emergency fasciotomy. My charge nurse and I helped get the patient down to the OR, and as we were walking out of the OR area, the original on-call resident was walking in and asked me why I did not inform her sooner of the patient's condition. Now, while there was a very strong communication between myself and the charge nurse, this experience showed me a clear breakdown of poor collaboration and how it could affect patient care. In an article from Harm Reduction Journal in 2019, it states drug use is experienced as a barrier at all stages of hospital care. Interventions to decrease stigma and improve our consistency and approach to pain management are necessary to improve the quality of care and care experiences of those who use drugs. It was due to this discrimination on the provider's end that led to the patient's negative outcome. If she had been willing to listen to my assessment of the patient and the drastic changes, then care could have been implemented sooner. Also, due to the lack of collaboration, we ultimately exhausted more financial and human resources, seeing as how we had to take the patient for emergency surgery. According to a 2019 article from the Journal of Interprofessional Care, current research evidences that continued poor nurse to physician communication is associated with increased length of stay in the hospitals, as well as greater patient error and harm. The physician and nurse must work hand in hand to care for patients. While the physician does have the ultimate power to make patient care decisions, they should also take into account the information from the nurses, seeing as how we're the ones spending the most time with the patients. The patient should always be the focus in any interdisciplinary team. Thank you.